It's my pleasure to introduce the two Nobel laureates, Dr. Joseph Murray and Dr. Donnall Thomas. It's a comparatively easy task in the sense that transplantation is so close to many of us. Journalists would love such a prize because they understand it. And many people would know about other people which have, let's say, in fact now become treated or cured by the modalities that the two laureates have introduced. Both Dr. Murray and Dr. Thomas have done their research in the United States. Dr. Murray in Boston, Dr. Thomas in Seattle. The title of, or the definition of the prize this year was, it was given for the discoveries of organ and cell transplantation for the treatment of human disease. This means, let's say, that if you give a prize for something which is achieved in relation to clinical treatment, it takes time. The achievements that the laureates were doing were initiated many years ago and are still continuing. They have done some absolutely pioneering, breakthrough research. And upon that has been added results from other scientists, which means today that transplantation is established as a clinical treatment, giving not only, let's say, prolongation of survival of life, but also a high quality of life. Dr. Murray, in his research, in essence proved that organ transplantation, kidney grafting, could cure a disease. It was must have been a fascinating situation when he had his two brothers, which he will talk about, where he realized that they seemingly were so similar that he could graft tissue from one to another, monozygotic twins. And opening up then not only showing that organ transplants could cure a disease, he followed up by showing that with certain other modalities, X-ray treatment and then applied chemical immunosuppression, it was possible to in fact get survival of kidney grafts between people which are not genetically related in such an extensive sense as the monozygotic twins. So it's with great pleasure that I would like to ask Dr. Joseph Murray to be the first lecturer today. No questions will be asked, no discussion will be allowed. The floor is yours. And you should just now talk about the first successful organ grafts in man. Please.
Thank you, Professor Wigzell, Professor Samuelson, ladies and gentlemen. It is, of course, a great honor to be able to present this Nobel Prize lecture, which is entitled The First Successful Organ Transplants in Man. Everyone in this audience realizes that progress is never the result of one person, and I would like to preface my lecture with two slides. May I have the first slide, please? This is a quotation of Tom Starzl's on the 25th anniversary of the first successful identical twin case. This was published in the Journal of the American Medical Association in their 100th anniversary volume. And this is what he says in that article. If gold medals and prizes were awarded to institutions instead of individuals, the Peter Bent Brigham Hospital of 30 years ago would have qualified. The ruling board and administrative structure of that hospital did not falter in support of the strange objective of treating end-stage renal disease, despite the long list of tragic failures that resulted from these early efforts, leavened only by occasional encouraging notations such as those in the identical twin case. Those who were there at the time have credited Dr. George Thorne, chairman of medicine, and Dr. Francis D. Moore, chairman of surgery, with the qualities of leadership, creativity, courage, and unselfishness. And I would like to stress the word unselfishness that made the Peter Bent Brigham Hospital a unique world resource in that moment of history. May I have the lights, please? The great pleasure is added because Dr. Thorne and Dr. Moore are both present in this audience. And I thank them in behalf of all of the residents and fellows that you have led and given us the chance to show our wares. Now, renal transplantation has been performed sporadically from the first half of this century, but planned programs for human organ transplants were started by clinicians in the 40s in Paris, London, and Boston. We did this in unmodified human recipients despite the warnings and the pessimistic predictions that many of the scientists and experienced clinicians. Now, many bioscientists have difficulty understanding the determined optimism of clinicians who are willing to evaluate any type of treatment that might possibly help these terminally ill uremic patients, most of whom were young and otherwise healthy. There were tantalizing reports surfacing of human renal transplants, some not substantiated and some with an element of truth, and this gave hints of success. In this lecture, I am going to focus on the transplant program at the Peter Bent Brigham Hospital, now called the Brigham and Women's Hospital in Boston, and try to explain how this small hospital became involved in transplantation. The medical and surgical services led the way, along with the Department of Pathology under Dr. Damon, and ultimately renal transplantation involved most of the hospital in one way or another. Lights and slide, please. The pathways of successful organ transplants have three paths. Study of renal disease, a study of skin grafts in twins, and a surgical determination. A leitmotif, next slide. Next slide, please. A leitmotif through all of these pathways is that a single event or report could be decisive in medical progress, and I think this will become obvious as we go on. Renal disease and hypertension was the major focus of the medical service at the Brigham. May I have the lights, please? The first two professors of medicine at the Brigham, Dr. Christian and Dr. Sommerweiss, were interested in renal disease. And when Dr. Thorne came in 1942, he and his associate, Dr. James O'Hare, continued their interest in renal disease, especially the relationship of renal disease to hypertension. After World War II, Dr. Thorne invited Dr. Willem Kolp from the Netherlands to Boston to demonstrate a dialysis machine which he, Kolp, had developed during his forced confinement by the Germans. Dr. Karl Walter of the Surgical Service helped improve the design, and thus the Kolp Brigham artificial kidney was devised. It was first used in patients in 1948 and set the stage for new innovative approaches to acute reversible renal disease and end-stage renal failure. The presence and the possession of the dialysis mechanism was absolutely essential for the progress of the transplant program. Because renal dialysis was only temporary in its improvement, it was logical to seek a more permanent therapy. And chronic dialysis was not developed until 10 years later by Scribner in Seattle. Now, in the late 1940s, during a grand rounds at the Brigham, I was a resident, and I was sitting somewhere in the back row, and I heard Dr. Thorne say, "The best way to treat hypertension is to remove both kidneys." The entire audience gasped. It was like stating the best way to cure a headache is to chop the head off. But the seed for the renal transplant program had been planted. Next slide, please. We will now follow the story of skin grafts in twins. This thread of the story involves the biological phenomenon of twinning, both monozygotic and dizygotic twinning. In the 1932, Dr. Paget of Kansas City reported the use of skin allografts in severely burned patients. These patients were so badly burned that they didn't have enough skin to serve for their own donor sites. So he used skin from other, he used skin from other persons, relatives and non-relatives, to help temporarily carry the patient over until their own skin became available. Possibly some of you have not seen skin homographs, and I will show a patient whom I operated on in the early 50s, a young girl with about an 80% total body burn. She had just a very few areas of her own skin to use for grafts, and practically all of, I guess I've got to remember to use my pointer correctly, pardon me. These are the homographs in place with scattered autografts, and it's difficult to tell which is an autograft and which is an allograft, but the allograft from another person melts away, and it soon becomes apparent which are the autografts, those that are staying. And it took 11 separate operations to finally get this patient completely covered with her burn. So we knew that spare parts could be life-saving if only the grafting could be made permanent. Well, it was impossible for anyone to be sure whether the skin was living or not. You couldn't tell which single autograft or homograft was going to survive. And the clinicians observing hundreds of patients still were not sure. But one observation proved the point. This was a patient that James Barrett Brown skin grafted in St. Louis in the mid-30s. He felt that identical twins probably would be able to accept skin successfully. So this single observation proved that point without question. This was the only single ray of light in the problem of tissue and organ transplantation until Gibson and Medawar in 1942 and 43 published an article, The Fate of Skin Homographs in Man. This was during the war, and Professor Medawar, a zoologist, was sent to work with a plastic surgeon, Tom Gibson, in Glasgow. And they applied skin from one person to another, and of course it was rejected. But when they applied the second graft from the same donor, it was rejected more rapidly than the first. And this was the so-called second set phenomenon, and it established rejection of skin as a biological problem that might be soluble. Now, Emil Holman had worked on burns in the 1920s, and Barrett Brown had worked on burns in the early 40s. Both had noticed that second grafts seemed to be rejected more rapidly than the first, but they did not formulate a basic principle from their observations on which others could build. And again, it illustrates the fact that medical progress depends on an observation which is not only made, but recognized and published as definitive. That's the monozygotic twin. Now the dizygotic twin, the non-identical twin, goes back to John Hunter. Practically everything seems to go back to John Hunter. But in 1779, he tells about the Freemartins, which were even described in ancient Roman times. And he tried to describe what it was, or to find out in the physical description of these animals what gave them their biological functions. Now the trail stops and is not picked up again until 19 1917, so that's a century and a half later. This is a free marten cattle. Free martens are dizygotic twin cattle, one sex, one male, one female. The male is always normal, and the female is practically always sterile. And I think you can see the I think you can see the undeveloped udder on this sterile female, and also the more ox-like build of the animal. When these occur to the dairy farmer, they can be quite a financial catastrophe because they obviously are not good for the dairy industry. The trail picks up again, as I said, in 1917 when F.R. Lilly published this article in Science. Now, Lilly was studying the free marten, and he refers back to an article by a person named Cole in the same issue of Science. And Cole had studied the records of 303 dizygotic free marten cattle, and he didn't come up with any particular conclusion. But I've always thought that Lilly was maybe a surgeon at heart, because he found 4 sets of free martens. He rolled up his sleeves, he dissected them out, and he dissected out the placenta on these free marten, and he found that they shared blood between the male and the female. Then the trail dies again and is picked up again 30 years later by Ray Owen. And Ray points back 30 years have passed since Lilly demonstrated the union of the circulatory system of the dizygotic bovine twins. And he went on and found that they shared the blood vessel, red blood cells, and they were really a red cell chimera. And then the trail proceeds more rapidly because we have Anderson, a veterinarian working with Billingham, Lampkin, and Medawar, and they skin grafted these monozygotic and dizygotic twins to distinguish them. And they found that the dizygotic twins were able to maintain reciprocal skin grafts. And then the report culminates with the report of Billingham, Brent, and Medawar on their actively acquired tolerance of foreign cells. And most of you know that they injected cells neonatally and intrauterine from disparate strains of mice, and found that the injected animal could then accept skin from the cell donor. They point back an exact comparable phenomenon was observed by Owen, who found that his findings in Nature. And then the Professor Woodruff in Edinburgh found some human twins, fraternal twins, one male, one female, who had shared the same red cell type, and he cross-skin grafted them and found that the grafts would be permanently successful. So that shows that it was possible to breach an immunological barrier using the dizygotic twin. Now, the next trail, and the final trail, is that of surgical determination. Lights, please. In 1912, Dr. Alexis Carrel won the Nobel Prize for, quote, recognition of his work on vascular suture and the transplantation of blood vessels and organs. He clearly recognized the difference in survival times between autografts and allografts in experimental animals, but he did not conceptualize rejection as distinct from other graft-destroying processes. Quimby used the canine renal autograft model to study the effect of denervation on renal function in 1916. And Mann and Williamson in the 20s at the Mayo Clinic noted different survival times between canine autografts and allografts, but like Carrel, they did not pursue the long-term fate of the autograft. And after World War II, Dempster in England and Simonsen in Copenhagen published extensively on canine renal transplantation, concentrating on the biology and the biochemistry of allograft rejection. They demonstrated that skin and kidney allografts had a common antigen which could sensitize the recipient from either tissue. And in all of these reports, however, there is the tacit assumption that renal autograft function would deteriorate ultimately, presumably because of lack of nerve supply or blood supply or some other physiological factor. Well, from a physiological factor, it was important to establish, if human renal transplantation were ever to be useful, we had to prove that a renal transplant, in the absence of an immunological barrier, could function permanently. And in the course of many laboratory experiments, I devised a reproducible model in the dog of a kidney graft in the kidney autograft. Here is one autograft 2 years after being performed. Here's the renal artery anastomosis. Here's the vein. Here's the ureter put into the bladder. And with the help of Dr. John Merrill, our nephrologist, and Dr. Neil Bricker, we studied these animals critically and found absolutely perfectly normal function in a renal autograft. So we knew that we had a good surgical model for transplantation. So the trails merge at the Peter Bent Brigham Hospital in the late 40s and early 50s. All the elements of a sound transplant program were in order. We had experienced knowledge in treating renal disease, we had the availability of dialysis, and we had skilled imaginative surgeons. Now, to minimize morbidity, the first allografts were placed in the thigh as a third kidney under local anesthesia. Dr. David Hume performed these operations, and the urine was collected from the thigh with a ureterostomy bag. Several of these allografts functioned far better than our laboratory experience would have predicted. One thigh transplant functioned almost 6 months, and with the return of the patient's biochemical profile and blood pressure to normal, demonstrating that the transplants could rectify the pathophysiological disorder of renal insufficiency. There was a first renal transplant done on the wards at the Brigham in 1945, which functioned slightly, and the patient did recover from her ATN, but that was really not germane to the progress of our story today. In the fall of 1954, this is the ureterostomy of that thigh transplant. And I can recall looking at that with Dave Hume and would say, gee, right there is the interface between the recipient and the donor. And we're not seeing any reaction at all. But there was the mystery, the enigma, which we couldn't solve, and even though we were looking at it directly. Well, the trails really emerged in December of 1954 at the Peter Bent Brigham Hospital. Dr. Miller of the U.S. Public Health Service telephoned Dr. Merrill in order to refer a patient with severe end-stage renal disease. Moreover, Dr. Miller suggested there might be an opportunity for transplantation of a kidney because the patient had a healthy twin brother. And needless to say, the transplant team was interested in the possibility of transplanting a genetically compatible kidney. Cross-skin grafting established genetic identity along with many other tests, but this was the acid test. His renal disease was brought under control by medications and dialysis, and we were ready to apply our laboratory-tested surgical technique to man. May I have the lights, please? So we had everything in place, but there was one critical factor that had to be explored. That was the ethical decision concerning the removal of a healthy organ from a normal person for the benefit of somebody else. For the first time in medical history, a normal, healthy person was to be subjected to a major surgical operation, not for his own benefit. After many consultations with experienced physicians within and outside the Brigham, with clergy of all denominations, we felt it reasonable to offer the operation to the recipient, the donor, and their family. We discussed in detail the preparations, the anesthesia, the operations, possible complications, and the anticipated result. And at the conclusion of the last preoperative discussion, the donor asked whether the hospital would be responsible for his health care for the rest of his life if he decided to donate the kidney. Dr. Hartwell Harrison, the surgeon for the donor, said, "Of course not." But then he immediately followed sympathetically with a question, "Ronald, do you think anyone in this room would ever refuse to take care of you if you needed medical help?" Ronald paused and thought, and then it dawned on him and he realized that his future depended on our sense of professional responsibility rather than on legal assurances. Once the patient and the team decided to proceed with the transplant, an extra professional burden falls on the surgeon performing the donor nephrectomy because his patient is expected to survive normally. In contrast, the surgeon performing the transplant, myself, I was operating on a patient who was otherwise doomed to die. And the nephrologist, Dr. John Merrill, who cared for these critically ill patients, could not be faulted if he could not cure terminal disease. Lights out, please. Slide. The operation was performed in December 23rd, 1954. The donor was operated on in one room and the recipient in another. Here is the transplanted kidney in position, just like it was in the dog. At that time, we did use a suprapubic cystostomy because we weren't sure of its function, but we had immediately abandoned that once we found that these kidneys functioned perfectly normally. We placed the kidney in the right lower quadrant, retroperitoneally, and here it is sitting in place comfortably. And I can recall with certain humor now that we were worried about this kidney's safety, and we even devised plastic coverings for it, hoping to protect it from trauma. But we found the patient wasn't interested in it at all. It was protected by the abdominal musculature, and it has proven to be a very safe site for the transplants. And this is the same operation which is done essentially to this day. Now here are Richard and Ronald leaving the hospital about 2.5 weeks later. The result was spectacular. We never dreamed that the recovery would be so rapid. The day after the operation, the patient looked like a new man. He had a sparkle to his eyes. He began to get hungry, and within a couple of weeks was ready to leave the hospital. This spectacular success was a clear demonstration that organ transplantation could be life-saving. In a way, it was spying into the future because we had achieved our long-term goal by bypassing, but not solving, the issue of biological incompatibility. Now, the impact was worldwide, and it stimulated widespread laboratory attempts to breach the immunological barrier. Here is the team. Here is Richard, the recipient, and myself. Here is John Merrill, the nephrologist in charge of all of the renal management. And here's Hartwell Harrison with Ronald. And I only wish that Hartwell and John were here today to join in this marvelous celebration. But both of them passed away within the past decade. And this is the first publication in the Surgical Forum, 1955, Renal Homotransplantation in Identical Twins. And we described in that paper the only exception ever of a successful kidney transplant was one done in a dizygotic bovine twin. And that was done by Mort Simonsen in Copenhagen, again showing the effect of the placental intermingling of blood. Well, we started on many experiments along with people all over the world, and experimental protocols included total body irradiation followed by marrow infusion, immunoparalysis by multiple graftings, immunological enhancement or adaptation by prior exposure of the host and graft to antigen, matching of the donor and recipient by red or white cell typing, and the use of drugs such as toluene and nitrogen mustard to depress the immune response. Well, we continued on several fronts, and I must stress that each department had their own laboratory program. The medical group under John Merrill had their program, Dr. Damon did, and we did too. But we collaborated, I think, as you can see. I will retrogress a bit. Peter Medawar was one of our great fans. He would visit our hospital and laboratory very frequently during the 50s, and he encouraged us a great deal. And he published some 35 years later this report. At that time he was talking about cancer, and he felt that there was a need for surgeons to become involved in cancer. And he used as an example the fact that surgeons had become involved in immunology and transplantation. And he said that for progress in cancer, just one brilliant break is needed, akin to the first brilliant kidney transplant at the Peter Bent Brigham Hospital in Boston. And then recruits will come forward by the hundreds. This was written just about 5 years ago, just before his death. Well, we continued both clinical and laboratory studies. We thought the uremic state itself might be immunosuppressive, so we did some skin grafting experiments in humans, and you can see Dr. Damon examining a series of experimental skin grafts. And we did determine that the uremic state was immunosuppressive, and that might have accounted for some of the prolonged survival of some of the earlier unmodified kidney transplants. We also studied bone marrow and total body radiation in mice, and we had all various protocols. Here's one using isologous marrow, and then we'd use skin grafts from third-party donors, and we achieved a moderate success in the experimental animal, both in the mice and in the rabbits. And the late Richard Wilson did a lot of these experiments using rabbits with multiple skin grafts, total body irradiation, and multiple skin grafts from multiple marrow donors. And then we would follow the fate of the skin grafts, hoping that it would help us to understand whether more than one type of marrow would survive. None of these protocols seemed to be too successful, and they weren't applicable to man. However, we were getting quite a few patients referred during the 1950s to the hospital, the patients who had lost a solitary kidney. And we felt that we had enough possibility of success to try to use the total body radiation marrow protocol and then using an allografted kidney. We did 12 such patients between 1956 and 1962, and only one succeeded. Meanwhile, we had been having many identical twins coming through the hospital, And here is an identical twin who came in 1956. And the sick twin is here, the healthy twin is here, and both had been recently married. This is the cystogram on the donor. It's not an intravenous pyelogram, it's a cystogram. And it shows a ureteral reflux of the dye up into the kidneys. Now this can be an ominous sign, especially if a person is going to have a future pregnancy. And this posed a great problem for Dr. Harrison, who was the surgeon for the donor. But after a great deal of discussion, we decided that the risk was small enough to go ahead, and we did remove her kidney and transplanted it to her sister. Here is the chest film on the recipient. Within a couple of days, you can see that the cardiomegaly has decreased, the lung, pulmonary edema has decreased, and she had remarkable rapid recovery. She was operated on in 1956. Well, she came back in 1958 with this well-developed pregnancy. She had been amenorrheic because of her uremia and had lost track of her periods, and without realizing it, she had about a 5 or 6 month pregnancy. We didn't know what to do. We didn't know whether the kidney would be compressed by the baby's head. Here you see the intravenous pyelogram, the baby's head quite close to the kidney. We took her into the hospital, kept her there, and delivered her by cesarean section in March of 58. At the time of the cesarean, I could feel very easily that the head was not impinging on the renal vessels, and we realized that she could have had a normal vaginal delivery. She was the world's first kidney transplant patient to have a child, and here she is a few years later. This is Edith with her 2 children, the recipient, and here's Wanda with her 3 children, and a few years later, we have quite a crew. And they live in Oklahoma, and I just spoke with Edith last week, and she sounds just like she did 30-odd years ago, just fine, is the way she always responds when you ask how she is. And she is now the world's longest living renal transplant. The first twin died at 8 years of a coronary artery problem. Now, I mentioned that each group were doing different experiments. This is an experiment that John Merrill's group were doing. They were trying to use skin grafts to type individuals. And this was experimental sensitization of humans, and he was creating a sensitized white graft by previous immunization with white cells. So it's kind of paradoxical, and I think it shows how the hospital worked. Here was John Merrill, a nephrologist, doing work with skin grafts, and here was I, a surgeon, working on some renal physiology. But I think the hospital just worked as a unit, and it was a marvelous place, and is a marvelous place for progress. Now here is the non-identical twin who was radiated. He was the one success out of 12 that we had between 1958 and 1962. You can tell that they are not identical, and this is the site of a bone marrow biopsy. We did treat John with total body irradiation in a sublethal dose because we had lost the 2 previous patients because of marrow insufficiency. We did skin graft them to prove that they were not genetically the same, and here's the graft in the uremic sick person still present, but you can see that the skin graft in the healthy person is being rejected rather violently. Well, here they are about a year later. Here's John, and here's Andy Retiris. They were Latvian extraction. John lived for some 25 years, died of cardiac insufficiency after a coronary artery bypass just about 4 or 5 years ago. and he is the world's first successful allografted kidney transplant. Well, this is where we were at the end of 1960. We had the Helm twins, these are the Jimmy Ray twins, and we had the Rateris twins who were non-identical. We had at that time about 10 sets of identical twins. We knew we had a good operation. All we had to do was break the immunological barrier. Well, the trail expands. Immunosuppressive drugs. Dr. Hitchings, Dr. Elian, who were here 2 years ago, and we're pleased to have Dr. Hitchings here today, had developed 6-mercaptopurine as an anti-cancer drug. Bob Schwartz and Bill Damashek, 2 hematologists at Tufts in Boston, took some of that drug from Dr. Hitchings, used it with a protein injected into a rabbit, and found that this drug could produce a tolerance to the protein, injected protein, which was given at the time the drug was administered. And the important point was that after the drug was discontinued, the tolerance still persisted. So the drug, immunosuppressive drug, was tested on a foreign protein by Schwartz and Damashek. It was immediately applied to the dog kidney system by Roy Kahn in London, by Charlie Zukowski down in Richmond working with David Hume, and by Jim Pierce, who was out in Minnesota at the time. Roy Kahn came to work with us in Boston at the suggestion of Peter Medawar, and he brought some of these drugs with him from Dr. Hitchings and Dr. Elian. And 6-mercaptopurine is an adenine analog, it's an antagonist, and the BW57322, which is the imidazole derivative of 6-MP, is now called Imuran. Well, Dr. Hitchings and Dr. Elian supplied us with several drugs during the 1960s and 61s, and it was without a question the most dramatic breakthrough that we had witnessed. I had worked all during the 50s operating on dogs, trying to make them uremic and trying to make them damaged so that we could have successful transplants. And I've operated on more than 500, and I never got a survival beyond 15 days. But with the advent of 6-mercaptopurine, we soon had dogs surviving. This is Marietta, George, you may remember, the first real long survivor. This was 38 days. The drug dosage of 6-MP you see here. The blood urea nitrogen level is pretty good. The white count went down, and this dog died of pneumonia because of leukopenia. So we had over-treated the dog. But we tried many combinations of drugs. And here is a favorite of all of us, a dog called Lollipop. And Lollipop lived 112 days. Notice the BUN has no protein in it. One blip here, maybe a rejection. At this time, we were using 6-MP and Imuran. 322 is Imuran. The white count was satisfactory. Specific gravity of the urine was fine, and the BUN you see is perfectly normal. We knew we had something good. Here is the intravenous pyelogram on Lollipop. And you can see a beautiful kidney functioning, small ureter, calyces pointed, sharp, perfectly normal kidney. So we felt that the time had come to proceed to the human. Here is Guy Alexander, another one of our research fellows, with a group of dogs that we had in the laboratory at that time. This is on the steps of the Harvard Medical School. One of our dogs developed a severe osteomyelitis of the mandible. And I thought certainly with being immunosuppressed, the infection would go on and kill the dog. But we treated the dog well. I think we extracted the tooth, kept the wound cleaned, and the dog went on to heal. So we knew that we did not have an immunological cripple, and that was a condition that we feared we might have. One dog gave birth to a litter of pups, and these pups were sired by a drug-treated, allotransplanted male dog. And so we knew that the drugs would not prevent pregnancy. Here's a dog that survived 1,000 days. So we had a party. And this is the laboratory. This dog, we used to run out of names, so we were naming it after the states in the Union. This dog was called New Hampshire. And here are a couple of our attendants, Bill Barry and Haywood. And we had a lot of fun, and it was a very exciting time. And here is the picture that I like to show, because here is Roy Kahn working with us. Larry Ayers, a college student, filling in time. Here's Trudy Elian and George, who won the Nobel Prize just 2 years ago. And here's a representative of Burroughs Wellcome, Ted Hager, a medical research fellow working in our surgical lab, and myself as director of the lab. Now, we tried to figure out, I think George tried to make biochemists out of us, and it was totally hopeless, but we did try to figure out a priori what drugs would work and where they would hit on the purine synthetic cycle. And I won't go through all of this, but I must confess it was a marvelous intellectual challenge to try to figure out which drugs were going to work the better and which ones might be discarded. Well, we went to the human at this stage, and this is the beginning of 1961. And this is a patient that George will remember, Donnall Thomas. He was a 6'3" fellow who was dying of renal disease, and a kidney was being removed to be discarded by the neurosurgeons. At that time, they were doing ureteral shunts for hydrocephalus. So there was a baby infant kidney available, and we put it in this 6'3" fellow, and I think you can see the dialysis and the transplant. The renal function was quite good. The BUN came down. The white count, unfortunately, went down. We had to stop the drug, and he went on and rejected. The drug used at that time was the same as we used in the dog, which proved to be 4 times that of the human, and we overdosed the patient. And here are the urine collections from Donald, and needless to say, we would be gleeful when we'd see the 4 a.m. to 7 a.m. collection within a day or two after the transplant. Our second patient was René Gregoire, and he had a hypertensive nephrosclerosis. He had a cadaveric transplant, and his BUN came down well. We'd halve the dose in him, but he still got leukopenic. We had to decrease the drug, and then he began to reject. But this was an interesting patient. We did an open exploratory biopsy, found the kidney looked fine. It did have some rejection cells in it. By that time, his white count was coming up, so we increased the drug dosage, and we had quite a clearing of the cellular infiltrate. And this was the first indication that we had that the rejection process could be reversed. At that time, it was assumed it was an all and none phenomenon. Well, our third patient was Mel Doucette, operated in April 1962, and he survived for over 1 year. He had a stormy course, but he ultimately survived well. I won't go through all of the details, but here is Mel Doucette, a year or 2 after his cadaveric transplant, and he was the world's first successful cadaveric transplant. And because of the success we were having, we and other groups around the world began to use these drugs, and here are 4 successful transplanted patients: Donald Messinger, a transplant from his father, Harold Rose from his brother, and Bob Canada from his mother, and Doucette from a cadaver. So we knew that something was worthwhile, and I think this was the beginning of clinical transplantation on a worldwide basis. Now, briefly, I will conclude by a follow-up after this. We didn't have total success with every patient, I assure you. Each patient had to be cared for critically and carefully. Here is a patient named Dick Durand, who we transplanted in '68, and he needed an aortic valve replacement. And I can recall either arguing or discussing, depending on which participle you wish to use, with our cardiac surgeons. We said, fix his valve and then we'll do the transplant. And they said, no, do the transplant and then we'll fix the valve. Well, we went ahead and got a cadaveric transplant, and it worked very well. Urine volume you can see, azathioprine, steroids, and then some 6 months later, he had his aortic valve replacement. And Dick Durand survived some 23 years and succumbed of vascular problems. And another anecdotal patient, this was a lady who had a cadaveric transplant. This looking at the left lower quadrant of the patient. Here's the umbilicus, here's the pubis, and this is the upper part of the left thigh. This cadaveric transplant was functioning marvelously, but all of a sudden it stopped one night, and I was called in, and they said that Mrs. Negri has a tremendous infection. And sure enough, she did. Her whole abdominal cavity was distended, and the only thing one could do was do an open drainage. And I will never forget just opening up the incision, and we had to drain exudate from the diaphragm down through the pelvis. The entire peritoneal cavity was filled with exudate. We couldn't possibly close this, so we left it wide open. And there for a few weeks, or a few days, we had a kidney out in the open and drainage around it. Well, gradually she got better, and we decided to take a skin graft. So we have another interesting biological problem. We have an autograft on an allografted kidney. And we observed it with great interest, shook our heads wisely, and didn't quite know what to do, but finally, when she got better, we excised the graft and closed it over, and she went on and survived for another 20-odd years. So these were some of the anecdotal experiences that we were having as we went on and did more and more transplants. Well, the success of renal allografts, of course, led to the attempts of other organs. There was a discussion at that time about which is better, transplantation or dialysis. And John Merrill and I used to appear in many panels together trying to point out that there was no conflict. There were complementary ways of treating the patient. Some patients would do better one way or another. But here are some of the actuarial survivals. Living-related transplants, at that time there were about 300. They were, 8-year survival of 70%. Cadavers were about 40%, and these were figures from the National Dialysis Registry. Here we were in sibling donors. Before 1966, we did 147. This is the worldwide registry. We had a kidney transplant registry worldwide, and we had about a 40% 4-year survival. If we did them after 66, they get up to about 70%. Of course, during this time, there was increased activity in kidney preservation, white cell typing, HLA typing, and many other factors were contributing to success. Now, here is a cadaveric survival curve, and you find it's quite low. The first few years, 400 cadavers, only a 20% survival. The next 66, 67, we were getting a 2-year survival of about 40%. And then the subsequent 2 years, we started off with about 60%. But multiple factors have occurred since then. New drugs, cyclosporin, and we now have patient survival in the 90 percentiles, and in the kidney graft survival, depending on, this is living-related donors and cyclosporin and prednisone, we have a 2-year survival of about 80%. So we can see that we've come quite a way. Well, what other organs have been transplanted as a direct result of this? Kidney transplants, there are over 20,000 every year done, counting the United States and Europe. And you can see the increasing numbers and the graft survival increasing as well. Now, following, the next organ was the liver. And Dr. Moore had worked out the technique of liver transplants in the lab, and Dr. Tom Starzl did the first successful liver transplant in humans, and he and Roy Kahn have done, up until a few years ago, the bulk of liver transplants. And you can see the numbers of liver transplants rising rapidly. So we have 1,600 now. Heart transplants, Shumway and Lauer developed the technique where they went very carefully and very slowly and developed the program. There was one period of time, I think transplantation's darkest hour, when a few cardiac surgeons who didn't have much immunological background sort of entered the fray, possibly prematurely, and it really, I think, set back transplantation quite a bit. But thanks to Dr. Shumway and his steady program, cardiac transplantation today is established form of therapy, especially with cyclosporin, and you can see the numbers. Pancreas transplants, we're up to 200. And these are just from the U.S., and I think the European group are about the same or maybe a little larger. But in the past 3 years, you see the number of liver transplants gone up to 2,000 in 1889. Hearts, 1,600. Heart lung, 75. Pancreases, 400. And the kidneys, about 8,000 or 9,000 a year. So it's been a marvelous story. It's not a one-man story. I think that everybody knows that. It's all a team effort. It's part of the worldwide experience that we physicians have in trying to eradicate disease. I'm not sure where the future is going to go. There's so many problems with drug therapy that we are looking for ways to establish compatibility. May I have the lights, please? And although thousands of young lives have already been saved by various immunosuppressive regimens, serious complications still result. And the ultimate aim is to achieve an immunological tolerance between the donor and the recipient, eliminating entirely the need for drugs. Now, there are hints, both in the laboratory and in man, that the liver itself can produce tolerogenic factors that may reduce or eliminate the need for immunosuppressive drugs. Discovering or uncovering naturally occurring immunosuppressive substances, in my opinion, seems possible. It surely is as probable as the prospect of obtaining successful organ transplants was 45 years ago. Thank you.